shortly. And then we have Jane Ashcroft, who's joining us online. So, Jane, over to you first. Could you just introduce yourself and say who you are, please? That can be helpful to start our proceedings.
Thank you, Chair. Good afternoon, everybody. I'm Jane Ashcroft. I'm Chief Executive of Anchor. We're a not-for-profit provider of housing and care for older people. So we provide a range of retirement housing, extra care and residential care services to about 60,000 older people working in 85% of local authorities across England.
Okay, and in the room with us, Steve Scown.
Good afternoon, Steve Scown, Chief Executive Dimensions, largest not-for-profit provider of services for people with learning disabilities and autism, employ 7,000 colleagues, support 3,000 people in 90 local authorities, providing residential care and supported living.
Right, you're welcome as well. And Dr. Jane Townson.
Thank you. Yes, I'm Jane Townson, Chief Executive of the Homecare Association. We represent and support 2,350 providers across the country, and ranging from very small to very large, from predominantly state-funded to predominantly private pay-funded, generalists and specialists.
Right, thank you all for coming to be with us this afternoon. Members of the committee will ask questions. They will put them either to one of you, or then one of you, then the next one, or they'll ask an open question and then any of you can come in who wants to answer it. Andrew Lewis, to start off on the funding pressures.
Thank you, Chairman. So this committee last explored the issue of long-term funding of social care in 2018, along with the Health and Social Care Select Committee. So can you explain how pressures on the adult social care system have changed since then, in the last 2 or 3 years, and how COVID in particular has affected the situation? I'll ask Jane at Anchor first.
Thank you very much. Yes, over the last 3 years, a number of factors have impacted from our perspective on the adult social care sector. So significant increase in demand. We see both in our retirement housing and extra care services, where we have a significant waiting list, and also in our residential care homes, more people needing our services and seeking to move in and use our services. We've seen a reduction in the percentage of the people using our care services who are funded by the public purse, and an increase in the private payer percentage. So a slight move. We were previously just over 50% local authority funded, and that's moved down to just below 50%. Probably the most significant change I would note over the last 3 years has been the pressure on workforce. So we have seen a significant increase in turnover in some groups of our workforce, and we've seen the increased difficulty of recruiting. We've sought to invest heavily in our workforce over the last 3 years. We've got a range of activities to recruit and attract people, to retain experienced colleagues. We have a very strong commitment to training and development. And we continue to do that and seek to be ahead of the living wage, so that we're rewarding a very important and professional workforce. The period of the pandemic, despite the fact that in our care homes we've seen a reduction in our occupancy, we haven't seen any reduction in the need for workforce. The additional requirements of the pandemic, obviously in terms of supporting our residents, that's been our major focus, but there's also been additional requirements, extra workload around the management of the testing system, the management of the visiting, so that relatives can visit their loved ones in care homes, which has been incredibly important, and a range of issues around infection control, which have also been critical. And we've seen cost pressures, in addition to the cost pressures around workforce, also in relation to some of our other key areas of expenditure, utilities, food prices, and of course the need to provide more equipment for people to maintain high standards of infection control. So happy to talk about any of those in more detail, but those would be my summary comments.
Thanks very much. And staying with the Jane theme, over to you.
Thank you. Yeah, in addition to the things that Jane Ashcroft has said, I'd like to highlight increase of complexity of need. As numbers of people, older and disabled people needing support, have increased and funding has been squeezed, care has been rationed. And so in home care, in order to receive state funding, you effectively have to have fairly advanced healthcare needs as well. And the typical time that a person is in a home care service in the state-funded part of the market is between about 1 year and 1.5 years. So we're only really seeing people quite close to the end of life. And I think that is quite a big challenge when we start talking about prevention, because you need to start investing much earlier than we currently are.
Thank you.
We'll probably have a slightly different pattern, or certainly see things differently in the sense of we support working age adults with learning disabilities and autism. So we haven't seen the significant increase in demand that the two Janes have referred to. We've seen just a continuing trajectory of increasing demand at the same pace as before. I think we have noticed that people who we support who are not supported 24/7, i.e. have their own home, live on their own with a small package of hours, they are much more likely to have their hours reduced. And we've seen a number of examples where that has placed them at risk of certain issues. So, for example, we 3 years ago we would not have been talking about cuckooing. Now we are supporting people who are vulnerable to that sort of behaviour. In terms of our workforce, we had quite a good pandemic in terms of recruitment, and our staff vacancies reduced through the pandemic. I think people saw social care as a good thing to do, secure employment, valuable, rewarding. I think 6 months ago there was a tipping point where there's been a material change in that, and our turnover numbers have gone in totally the wrong direction since April. In terms of pay, we've struggled to stay above the national living wage. This year, we don't have anybody on the national living wage, but we are barely above it, and that's become an increasing challenge each year because our contract prices aren't increased the same rate as our costs.
Thank you. So, in order to take on all of that, last month the government published its plan for health and social care. And how far do you think the plan addresses the pressures that you've just described? And I'll stay with you, Steve, because the pressures you've described are slightly different ones.
Yeah. They don't, frankly. Mm-hmm. My understanding is the money, you heard from the previous witnesses how that money is going to be spent. I don't think our services that we're providing are going to see any benefit from that whatsoever. And certainly in terms of our staff costs and pay rates are going up. And today's announcement has added to that challenge. So, frank, blunt answer, it's not going to help us very much at all, I don't think.
Thank you. Jane?
I agree. For a start, the reforms don't come into effect until 2023. So we've got to get until then without any additional money that we know of at the moment. Strong hints, as was discussed in the previous session, that councils have got to find that extra money through raising council tax or generating efficiencies. And the whole, as Jane said, the workforce is our biggest challenge. In home care, we've just published data showing that the volume of hours purchased in the United Kingdom has increased by 11% just in 1 year. And as demand is increasing, supply is actually going in the reverse direction. Providers are reporting a 75% reduction in applications for jobs. Care workers leaving faster than they've ever known. And this isn't helped by some of the government policies as well, with regard, for example, vaccination as a condition of deployment. So we're really struggling in home care because out of all of the services, probably the one which is squeezed the most by commissioners. Home care often purchased by the minute at fee rates well below cost. So it's become almost impossible to pay staff what they deserve and to pay them fairly. And I mentioned earlier the complexity of need, the kind of training that they have to have now. And during the pandemic, that intensified. So care providers were asked to do wound care and administer insulin and verify death and all manner of things that they didn't have to do before.
Thank you. And Jane, anchor there.
Yes, thank you. My concern is that the supply of social care will be even further squeezed before the changes that have been announced are implemented. So, as colleagues have said, the short-term pressures are profound. In Anchor, our national insurance bill will go up by £2.5 million on the 1st of April. We anticipate that the fee increases that local authorities may be able to discuss with us will be in the region of perhaps 2%. And we are concerned that supply across a range of services. In our case, we have a small number of care homes at the moment where we aren't able to accept any further residents into the homes because we aren't able to attract any further staff. We have strong demand from potential residents and their families. We're very keen to work with local authorities and with the NHS on discharge. But the staffing issue is so significant. So I think the changes, as Steve and Jane have both said, are into the medium term. And while an impetus for change is something that we've been calling for, and we are pleased that there is a direction of travel, I think in order to get to the medium term, I'm very concerned about how we meet the short-term challenges.
No, right, thank you very much. Quite a few things there that will come up in the course of, I think, so I'll hand back to you, Chair.
Thanks, Andrew. Right, so the government, one of the government's proposals in the plan they announced was that self-funders can go to the local authority and ask the local authority to arrange the care for them at the price that local authority would normally pay for the care for people it funds. What is going to be the impact of that particular change? There's supposed to be money provided in the from the levy to cover that cost. Is that your feeling that that will actually happen? Have you got any idea what the impact of that's going to be? Just go Jane Ashcroft first of all on that, from your perspective.
Yes, I think we are concerned about the impact of that change without sufficient funding to bridge the gap. In the previous session, the witnesses identified the range of fees in care homes in different parts of the country. And if we look at the data from recent reports, there's a number of reports available. The range of care home fees, if I focus on care homes, is very significant in different parts of the country, with no direct link to the affordability of provision or the cost of delivering care, should I say, in those particular areas. So the introduction of a fair price for care mechanism and something which very clearly identifies the true costs of care delivery are going to be critical if a levelling up or levelling down is not to have a dramatic impact on the sector. And again, my concern is about the amount of supply which may fall away from the sector if providers aren't able to maintain a sustainable service.
Jane Towson, looking at across the board at the various of your members, how they're responding to this?
Well, in actual fact, Section 18.3 of the Care Act 2014 has already been brought into effect in home care, and some providers have experienced already councils putting requests for care for self-funders on their procurement portals at their rates. Now, in our studies of fee rates for home care, it's the areas of greatest deprivation that have the lowest fee rates for home care. And providers are really cannot make it work economically on those fee rates, because we have to be compliant with national minimum wage legislation, we have to be compliant with care regulations, and they don't vary depending on where you are in the country. So I think the real concern is that we're already in some places on the brink of sustainability anyway. If providers, especially, there's a lot of small and medium enterprises in our sector, over 85% have fewer than 50 employees, and many rely on a mix of state-funded and private pay-funded work to keep the whole thing going. If that gets taken away, we'll see many more providers having to hand back work, cease trading, sell their businesses, what we're already seeing, but maybe in a more accelerated fashion.
Just pick up one point before I come on to Steve Scown. You mentioned there the national minimum wage. The government's announced a 6.6% increase. Is that going to have a significant effect on your members, the care providers? Absolutely,
because in care sector in general, staff costs are a very high percentage of the total. In home care, it's about 70% of total costs. Care homes probably nearer to 60%. And unless that increase is funded, which in previous years hasn't always been the case, providers are going to struggle to cover those costs, because it's not just the headline rate, you've also got the impact of the on-costs, so the pension, national insurance, holiday pay, sick pay, and in the case of home care, travel and mileage. And we're likely to be quite badly hit by increases in fuel prices, probably over 5 billion miles driven every year in home care.
Yeah,
on the national living wage front, I spoke to my finance director this afternoon, actually, before coming in here, and the new national living wage rate, I need a 4% uplift next year just to stand still. And my average increase in contracts price for the last 3 years has been 2%. So you can see immediately there's a real issue emerging there. In terms of the other point you raised in terms of self-funding, that really doesn't apply to us, but I do think one observation I would make is that often government doesn't take into account the quantum of work to implement new ways of working. So we're working with local authorities who have a 50% vacancy rate on social workers. So that sort of issue is often under-evaluated by the government, I would say.
Okay, just finally, we talked about the challenge of increased costs and the fact that the levy isn't going to deliver here and now to meet those costs. So, looking at the spending review, 2 days' time, what would you, very briefly, don't want you to write the Chancellor's speech for him completely, what would you want to see out of there that would make an immediate difference? Steve?
If you're asking for a figure, I wouldn't offer a different figure to the one that was the previous session identified from the Health Foundation of 14 billion, I think is roughly the number by 2030.
Okay.
So I think it's important that we see social care as a means of investing rather than just as a cost. So Skills for Care recently published data indicating that the value of social care to the economy is about 50 billion. And international evidence shows that the foundational economy, having a strong foundational economy, health and social care education are part of that, is essential for the tradable economy to function. And we're a major employer. We employ more people actually than the NHS. And if those people earning money, they will be spending that in their local economies. So we would see it as a call for investment to help the economy, because without health, we can't generate wealth.
Okay. And Jane Ashcroft.
Yes, thank you. I would agree with Steve's point. I think the Health Foundation number would be a very good number to see in the budget. And I'd build on Jane T's point that the consequence of undersupply in social care is dramatic on the economy. We know there's 10 million unpaid carers, people stepping out of the workforce in order to provide care because they're not able to access it through any other route. That undoubtedly has an impact on many people's quality of life, but it also has an impact on the economy. So we do need to see investment in social care as an infrastructure investment, an opportunity to create jobs. Hopefully we might come on to talk a little bit about how housing-based options can help with the social care conundrum, and there's opportunities for investment there. So I think there are potential economic upsides which need to be considered, whilst also recognising there is a need for some immediate investment, and that Health Foundation number is probably as good a place. If I had an ask, that would be it.
Okay. But if you want to refer to the housing issue now, I mean, it's something that's obviously clearly important to your organisation. I'm happy to take your comments on that. That's it.
Thank you. That's great. I think, as you say, our organisation, because we provide a range of services for older people, we see the benefit of specialist housing for older people as a means of preventing people needing more intense social care services. So across Anchor, of our 60,000 residents, 6,000 of those people live in our residential care services, which are focused predominantly on dementia care. But the majority of our residents live in purpose-built retirement housing, most of them with no care provided because they're able to maintain a degree of independence. And we do think that's very relevant for the remit of this committee, further investment, further opportunity for the development of age-specific housing for older people, built in a way that fits into local communities, is connected to other generations. I know sometimes people raise concerns about building age-specific housing that isn't part of the community. We saw during the pandemic the huge benefit of retirement living services, where people were able to have support, were able to maintain a sense of community. We saw lower levels of loneliness and isolation in retirement housing services than for some older people who were shielding in their own community and weren't able to contact others. So we do, as an organisation, Anchor, along with other housing providers, have been keen to encourage the government, when thinking about planning requirements, when thinking about future areas for investment, to consider the development of older people's housing, not just for in its own right, but as part of the support for the social care agenda, to make sure there's a range of choices for all of us in later life, which can reduce the spend that the public purse is required. Just as one brief example, if I may, we did some work about the value of extra care housing and found that the public purse saved £6,700 for every extra care resident using the extra care service, compared to somebody living in the community or needing to move into a specialist residential care home. And we submitted information about that, Chair, to the inquiry through our written evidence.
Thank you very much indeed for those important points. The committee's looked at some of those issues, and supported that approach in the past. Right. Just in terms of the bit longer term, the government's promised a white paper now to look at issues to do with choice, quality, workforce, accessibility of care. So just say to, first of all, to Jane Townson, is that something on your agenda, looking at those issues? And has the government now been in touch with you to get your input into the development of that white paper?
We certainly had a rush of invitations to meetings to discuss different elements of this. I think what I feel is still missing, really, is an overarching strategy for our country. When my great-grandma was born in 1879, there were only 60,000 people over 85. We've now got 1.6 million or so over 85. By the time I get there, there'll be 3.5 million or more. And we can't cope now. So what are we going to do to shift the needle? And other countries, such as Sweden, for example, they invest heavily, as was discussed earlier, in community and home-based support. They've got 33% or more of their people over 80 supported in their own home. Here it's probably nearer to 10 or 15%. And the entire conversation is often just about care homes. That's what you hear from politicians, that's what you often hear from officials. We spent the entire pandemic turning up to every meeting saying, hello, home care exists. And actually there are twice as many people altogether, if you add in the people supported at home by informal carers, the people with unmet need, which Age UK estimates at 1.5 million, and the people receiving paid for home care, there's about 15 million people, compared with only 500,000 in the combination of care homes and hospitals at any one time. So we need to focus on them, because if we keep them well, there's then less pressure on the more expensive settings.
Steve Scown, has the government been in touch with you for your input into the white paper?
No, rarely would be the worst case. And the other thing I'd make an observation is the usual suspects get asked, and organisations representing service users are rarely asked in these sort of things. So I think that's something that the government should do more of. In terms of the white paper, I'd like to think that we could move away from seeing social care as one big single homogenous lump. There are very different parts to it. Services for older people are much closer, and there's much closer interdependence with the NHS. That's very different from the sort of services I provide for working age adults who want a job, who want a relationship, who want independence, who want to live on their own. We do look at social care through a lens of usually large residential care homes for old people, because that's the funding lens that's looked at. So I hope the white paper has some courage behind it, that we actually see social care as not being that lump. We saw that in the pandemic, with the guidance that the government was issuing was invariably aimed at residential care, and supported living was an afterthought 2 weeks later. My final point is workforce. I am fed up of waiting for a government workforce strategy for our sector. The select committees call for it. CQC have just called for it yet again.
We are going to move on. I think just one or two questions on that in a second.
Right.
Jane Ashcroft, any comments there about the white paper?
I would agree with Steve's comments about the diversity of the social care sector and the need for that to be fully recognised in the white paper and not seen through any one particular lens. I would also emphasise the need for the voice of providers and service users. It's notable that while local authorities have an important role to play, I think there is still an assumption often that if local authorities are involved in the debate, that means that the providers of care are involved. That simply isn't the case. The vast majority of services in social care are provided by the independent sector, and it's quite rare, I think, for the voice of providers to be involved in the debate. So I would very much call for the white paper to ensure that provider voice, as well as, very importantly, the voice of people who use services, is reflected, and certainly the need for a workforce strategy for the social care sector. I don't think there's anybody that's not calling for that, so we can only hope that one of those will be forthcoming very soon.
Right, and moving on to the workforce issues, Florence Eshellamy.
Thank you, Chair. And you've all touched on workforce in one way or another throughout the course of this afternoon. And I think Jane A, you mentioned 10 million unpaid carers. Carers UK actually estimate that's 13.5 million. As the eldest of three girls, growing up, I was an unpaid carer for my mum, my late mum, who suffered from a disease called sickle cell anemia. And, throughout this lockdown, Carers UK estimate that an additional 4.5 million people were now caring for someone. Big issues across the workforce. I think, again, Jane T, you mentioned 75% reduction in job vacancies and adverts. In all your views, what's your experience in terms of attracting and retaining staff during the course of the pandemic? And what do you think the outlook is for attracting and retaining staff beyond this pandemic? Steve? I'll start with you, Steve.
Okay. Our experience, I've referred earlier, our experience during the pandemic was quite good in the first year of it. I think we were able to attract people. Our recruitment rates went up. I think people saw it as secure. I'm not being funny. It was secure work. It was better than furlough or the dole. I think we've seen that reverse since April. So since April, we've lost 7.2% of our workforce. They're going for better paid jobs. So we are finding ourselves in an employment sense competing against the likes of supermarkets, coffee shops, hospitality, etc. So I'm quite pessimistic at the moment. Frankly, until we pay social care staff what they are worth, and that should be a parity with NHS colleagues, and that's a £7,000 uplift per person, social care is not going to be seen as an attractive a career as I think it should be. I've worked in it for 40 years. I love it. It's the best job I've ever had. But at the moment, it's just not an attractive proposition for young people. I think the government's decision to spend 500 million, I think it is, on the workforce, great move, absolutely great. And we do need to professionalise the workforce. We do need a far better career structure. I started as a student nurse. I'm chief executive, all the rest of it, so I've got a great career. But at the moment, it's not attractive, and diplomas don't pay you rent and don't stop you going to a food bank. And we just need to pay our colleagues what they're worth.
Do you think it's not just the pay, but equally the low status of the workforce in terms of the fact that, again, you've all outlined, and Jane A on Zoom, the demanding role and the fact that you're seeing, carers having to take on more responsibilities, including unpaid carers. Do you think that's an issue?
Yes, I do. Status is absolutely an issue. I think it was seen during the pandemic to be a valuable role, contribution. We stood and clapped for our NHS colleagues and our social care colleagues. The status, but ultimately, status requires pay.
Yeah, I think we're kind of in a similar position to the position that nursing was in 100 years ago, when people were clamouring for professionalising it, and we need the same. And the 500 million is obviously a positive step, but that only works out at about £111 per person per year. And I can't think of many people that could do many qualifications with that. Is it really enough to professionalise an entire workforce? That would be my question. And particularly, as I said earlier, the complexity of needs. I mean, 30 years ago, residents used to drive up to care homes in their cars and go off and play bingo and that kind of thing. Now, it's very much higher levels of frailty, dementias, and so on. And many people are at home with those conditions as well. So the skill, it's not just about healthcare skill, it's about softer skills, negotiating, dealing with conflict, dealing with family members who are very stressed. And if you're a registered manager also, you may have to go and find clients, and that the roles are incredibly challenging. And in other walks of life, nobody would dream of running a £3 or £4 million business for 40k.
Jane?
Yes, thank you. You commented on the updated number of informal carers. Thank you for that revised number. Many of the great people in my organisation have been informal carers, and that's what's brought them into care. And I think Jane and Steve have perfectly described the complexity of the work that we ask people to do. We ask people to do work which is emotionally demanding, physically demanding, intellectually demanding, and we have to reward that, and we have to absolutely recognise the professionalism. It also means that I only really want people who are talented and compassionate working in my organisation. So it isn't just a numbers game. And I think there's a real danger at the moment that because we're very focused on the number of vacancies and the real concerns about numbers, we've got to be very careful. We understand not just anybody can be a carer. Special people are needed and have to be properly supported. I am really concerned about burnout. I'm actually seeing, Steve described we recruited well in the pandemic, then things became more difficult at the beginning of this year because I guess the market opened up for people and other options were available. But certainly I'm seeing people now who are incredibly tired, and we're losing people in management positions and all the way through the delivery chain. And I suppose the other issue about status is very important. The clap for carers was absolutely critical and was much valued, but it wasn't going to put the dinner on anybody's table. And one of the areas where I would expect to see equivalence of status is around the vaccination issue, where I do think some of the care workforce in care homes feel that there's an inequity. There should be a parity across all health and care services.
We haven't mentioned migration either, which is having both a direct and an indirect effect. So, for example, hotels have normally relied on workers from other countries. That's obviously dried up, and so they're now targeting our sector.
Yes, yeah.
And certain parts of the care sector, London, the southeast, has got higher levels of people from other countries working there. But also areas like live-in care, so some forms of home care have care workers living 24/7 in somebody's home. Traditionally has a lot of recruitment from countries like Poland, and that's become very difficult. So, I think we've just got a general workforce supply problem, and that's not just confined to our sector. But that is, however much money people are trying to, some of our members are offering £12.50, £1,000 starting fees and all of that, but they're still not managing to fill vacancies.
Now, on the vacancies, so Skills for Care annual report stated that 105,000 staff vacancies been advertised on an average day in 2020-2021. So just on the vacancies, what levers do you think need to be in place to address that? Not just high vacancy, but again, you've touched on the high rate of turnover. And again, something that you've all mentioned in terms of the care workforce strategy. What do you think needs to be in there, and what more can we do to push the government to start that?
I don't think I'd add much more to what I've said previously, if I'm being honest. I do think you've got to pay people enough. absolutely agree with Jane. We need great colleagues to work with us because it's an incredibly demanding job. But we have to pay enough, and I will keep coming back. That's the first and foremost. Once you've paid people enough, you can then offer the career structure. You can then offer the training. You can then become what we try to be at Dimensions. We try to be a sticky organisation. We try to encourage people. And once they've joined us, they stick with us. Why? Because we offer a career structure. We offer great career development. But at the end of the day, you've got to want to walk through the door to do the job.
So I think I agree with that, and many people come into care because they want to make a difference. And in my previous role, when I was a provider CEO, we did have staff leaving to go to retail, but they came back because they didn't get that emotional reward from the work. I think in home care, yes, the pay rate is really key, but also how the care is commissioned and purchased has a big impact on care workers. So if you're electronically tagging care workers, paying them by the minute at very low rates, and in certain parts of the United Kingdom, there's in some areas the number of 15-minute visits, short visits, makes it really stressful because they feel that they can't meet the needs of the people that they're supporting, and then they go round in this permanent sense of guilt and worry. And so it's not just the money, it's how that money is used.
Yeah, no, just on that point, again, if you think about carers and staff in London, but then in rural areas, how long it then takes you to get from A to B. Well, throw in the traffic in London, it will take you quite a while to get from A to B anyway. Jane A.
Yeah, I mean, that's a good point. The ability for people to get to work. So clearly in the domiciliary care setting, travel's an issue, but actually in many residential care settings or extra care schemes, if we're not close to a bus route, if it's difficult to get somewhere, then that whole issue about how much we pay, the ease of getting to work, being a flexible employer is very, very important. Also, I noticed in the Skills for Care report that was produced recently, they noted that turnover rates were lower in establishments that had higher CQC scores. And I think that points to the fact, I think that's a really interesting dynamic. Better care is provided by a stable workforce because it's all about relationships. Colleagues get to know residents and those relationships blossom and the quality of care is great. But also people in care want to work somewhere where they're proud of, they want to be involved in high quality care. And so those two factors are completely mutually beneficial, and those have to relate to the funding of services and the way that services are provided.
I just follow that because the Office of National Statistics recently produced a report showing that care quality ratings in care homes are higher in areas where of lower deprivation. So the areas of high deprivation have worst quality ratings, and the quality is related to income and how much you've got to invest in training and pay and support and supervision. And what you want is to create a virtuous circle.
Yeah, no, not to disclose anything, but I've been alerted of some really serious incidents in my constituency as well, obviously representing a South London and a London constituency, high levels of deprivation, and there are some issues in some of those care homes. I'll leave it there, Chair. Thank you.
Thanks, Lawrence. Moving on to an issue which has been raised before, but we need to explore it further with you. Integration of health and social care. Brendan Clark-Smith.
Thank you, Chair. Hello, everybody. I just wanted to ask, and some of the evidence so far is this suggestion that the stabilisation of the adult social care market is going to depend on successfully integrating health and social care. It's just really to ask what's your assessment of the progress of that? How do we feel that it's gone so far, and have there been any regional differences? I mean, what is the experience of it at the moment? I think Dr. Jane, if I start with you, perhaps.
I think the word integration means different things to different people, and my concern about it is that people go straight to a kind of an organisational, structural solution or thinking. I prefer the word collaboration because on the ground, that's what really needs to happen. I mean, even within the NHS, people talk about the NHS as if it were some kind of single entity. It really isn't. You've got all these different trusts, you've got GPs working as independent businesses, you've got community pharmacists, and what unites everybody is the person that's receiving care, and it's joining things up for them so that it isn't you don't have to tell your story to 25 different people. And I think there are, some areas of the country that are doing a better job of that. But right now, for us as social care providers, it's really hard to engage in the conversations about integrated care systems and everything. And I think as well, all the time that the budgets are in silos, we're really going to struggle to make a difference.
So in terms of what needs to be in place, then you'd say the budget's the starting point for that?
Well, even in Northern Ireland, which has been held up as we've got the joint health and social care trust there, the money is still in separate streams. Homecare has the poorest fee rates of the entire United Kingdom in Northern Ireland, even though it's supposedly commissioned by health. So for me, that doesn't bode very well. And I think we've really got to understand the differences which Stephen and Tim raised earlier, that it's those social determinants of health that are so key to all of us, not just healthcare itself. So I don't know how optimistic I feel. We've been discussing integration for donkey's years, and we don't seem to be any further forward.
Well, just finally on that point, if you don't mind me asking, there's been some recent reports about the government maybe introducing a national care service. I mean, what would your take on that be?
Well, I don't think it's going to happen in 10 months of Sundays because it will cost too much. And, there was a question earlier about in-house provision, but on average that costs twice as much as outsourcing. If we can't even afford to pay for the outsourcing properly, whatever chance is there of having it done in-house? The reason it was outsourced in the first place is because councils couldn't make it work in terms of investment and all kinds of things. So, I think it's quite problematic.
Thank you. Steve, what's your take on this?
On 2 points. On integration, I don't understand it. I don't understand what it means. Your point is it means different things to different people is very valid. I think it's being seen through the lens of older people's services and the impact on NHS. I think services for working age adults, people with disabilities, is just not on that integration agenda at all from what I can see. In terms of the National Care Service, I don't know what that means. If it means the medicalisation of social care and the NHS being in charge of services for people with disabilities, it was the biggest retrograde step this country could ever make. I've spent 40 years trying to enable people with disabilities to have choice and control and get them out of institutions. NHS runs institutions. No, thank you.
Thank you, that's useful to hear. And finally, Jane Ashcroft.
Very little more to add, really. At a local level, we have some good relationships where we deliver quite integrated services. As Jane said, there can be a partnership model that works. My concern, I think it's too early for me to understand what the ICSs are about. My concern is about the cost of process and people will be more money that goes out of delivery and into managing a complex system. And I think that's one of the concerns is there is a lot of complexity. Every time we change the system, we seem to add resource and cost to the means of processing rather than putting the resource and the focus on the delivery of services to people who use services.
Thank you. Thank you, everybody. Thank you, Chair.
Thanks, Brendan. And finally, moving on to models of care. Bob.
Yes, some of the evidence that we've received talks about changing the model of how care is provided away from care homes to more domiciliary care and other community-based organisations. Do you agree with that process? And if so, how can the government actually encourage that development to take place? I'll start with Jane first and then literally go around, if I may.
Well, definitely we need to invest in home-based and community services. We're always going to need care homes and we're always going to need hospitals. Yeah. But just to deal with the demographics, what the aim, as I said earlier, should be to support people to live well at home. And that will mean as well, not just rationing it until what happens at the moment is we don't give anybody, we neglect people until a crisis is reached, and then they end up in an acute hospital and then maybe get discharged to a care home. So if we can put in that money at the front end, and so what we want the government to do is to invest. people talked about lots of billions earlier, that we must be getting close to 160 billion that the government is pouring into the NHS right now. I think councils only have a total of about 22 billion for all of the social care, even though it's many more people. So let's just, even if we doubled that, that wouldn't be outrageous compared with NHS spending. I don't know why we're all so lily-livered about asking for a decent amount of money so that we can look after more people in their own homes.
Well, I think the argument, I'm not I suspect the government would come back with, yes, where's it coming from, the taxpayer or some other form? Jane, can I ask you the same question?
Yeah, I certainly think that moving the model, care homes are specialist care for people with, often people living with dementia and or at the end of their life. There's definitely a role for care homes, I say, as a care home provider, but I think people, I want in later life choice. I think there are a wide range of options which can improve prevention, can improve well-being, and it would be most helpful if we could have support for the development across a range of tenures of retirement living options, multi-generational options. The number of older people in this country is growing, so the range of options that people need is growing. We know that in this country about 0.5% of the over 65 population live in some kind of retirement village, retirement housing environment. We're an international outlier. You know, if we move to 5%, just 5% of people over 65, we would need hundreds of thousands more units of retirement housing. And I think one of the things we've got to overcome is we talk about people wanting to age in their own home. And I think the image of the own home is this place that people have lived in, since they were in their early 20s. That's no longer real. People move around in different life stages and have different needs. I can live in my own home, and it can be a specific retirement village. It can be something that's purpose-built for later life. It's something I can buy or rent in my early 60s, and somewhere where I can age well, be less likely to fall, less likely to be lonely and isolated, less likely to need health and social care services. We've got to reframe the way we think about ageing and living longer, and having some kind of a proactive approach to ageing, which could include investing in a variety of choices for people in later life, would have a big benefit for the social care system, but would also have a big benefit for all of us, for the quality of life that we can look forward to in the future.
Okay, well, excellent, thank you. Steve?
Thank you. If we're looking at it from a working age perspective, people with learning disabilities and autism, I think the right models are there. I think rarely are they funded properly. I think the best models I've seen are when people have choice and control and have some independence and they're in control of the service they're receiving. So if we can do that properly, I don't think we need new models. I just think the models we're doing need to be done properly and funded properly. That's where the best outcomes are. And in terms of outcomes, I know the previous session touched on outcomes. I don't know if we're going to get a chance. Well,
funnily enough, that's my next question. So
okay.
You've anticipated it.
Okay, I'll try and answer that one then. I think outcomes, we should move towards outcome-based commissioning, but can we please have outcomes determined by the person?
You also, I think one of the benefits here, you're all professionals in this field. What do we mean by outcomes commissioning in this sense? Because I think it would be helpful for...
It's giving people the life that they want, rather than what some procurement officer thinks they should have. If you want to sum it up in an elevator pitch, ask people what life they want, and actually if you give it them and they're happy and they're in control of who supports them and they're making those choices, then that's, for me, that's a starter for 10 on what outcomes are around.
But there is a constraint on resources, and so do resources then constrain what you can do in terms of outcomes commissioning?
I think there's very good evidence where people understand what's available, they can make the best choice of how to use those resources to the best ends. There is no evidence that people with a personal budget want a bottomless pit. There is absolutely an acceptance that resources are constrained, there's a limit, but actually if you're going to spend £10,000 trying to give me a life, let me choose how that £10,000 is spent, not some procurement officer in a local authority office.
Okay. Outcomes commissioning.
On the subject of money and investment, though, when it's all being poured into the NHS, but to supposedly to help their elective recovery, but actually a lot of the reason that they're stuck is because they can't discharge people back to the community. So I think what we're trying to say is, the money that we have got, can we use it more intelligently? And with outcomes, at the moment, if you take home care, it's purchased by the minute. All that's measured is how many minutes a care worker spends with that person. Does that person...
Not the quality of what they actually do.
No, and I mean, at a big ICS level, we should be looking at things like healthy life expectancy, and then how does that translate? Sometimes just the simplest intervention, you know, Jane mentioned it about making sure someone's not lonely and connected to their community. That keeps their confidence. They're less likely to fall, less likely to need healthcare. There's evidence for that already, so it doesn't necessarily cost a lot. We just need to think differently about it, and I think one of our challenges is the mechanisms for actually doing the commissioning. Other countries have started to think a little bit more carefully about this. We're going to need a radical reform of our approach to commissioning, and I always find it interesting to think about self-funders in this regard, because they are their own commissioners, and actually why can't state-funded people have the same degree of control as somebody who's paying for their own care?
Jane?
Yeah, I think that's a point I wanted to emphasise as well. In the care home sector, because there are a lot of people paying for their own care, when you talk to somebody about what they want, in effect, they're talking about outcomes, how they want to live their life. And people spending their own money make choices about how to spend that money. I think that principle needs to be built into how we commission for outcomes. This isn't a procurement process. It isn't like buying a product and looking for the best value for money for pencils or food or utilities. It has to be about services. And actually, I don't think that commissioning for outcomes would cost more money.
Okay. Finally, round the panel. Sorry.
All I would say is if we do that, then we need to have a regulatory framework.
Well, I was going to come on to exactly that point. My goodness me. You anticipate the questions very well, which is obviously your personal assessment of the regulatory framework that we currently have and what needs to change, if anything. I'll start with you, Steve, as you posed the question.
Well, on the outcomes space, I think we need to have a regulatory framework that was prepared to measure and judge people on the outcomes and providers on the outcomes people are achieved, rather than the processes and the outputs as it is at the moment. I think CQC's strategy is okay. I'm waiting for them to deliver it, because what we experience on the ground is not in line with their strategy.
Jane?
Yeah, I think the intent of the CQC system is positive. I mean, it is hard to get an outstanding rating, and you do have to demonstrate improved outcomes. So I think a lot of the mechanisms are there, but as Steve said, not always implemented in the most consistent manner. And I think it's got worse during the pandemic. There's a lot of focus on, process, and it feels like trying to catch people out. And then there's, the regulation of, or the oversight, shall we say, at a system level, because, if the point we've made many times is that the quality of care is directly linked to how it's commissioned. If you're purchasing care at £12.68 an hour by the minute, how can you possibly expect a provider to do a good job when you can't even pay your staff properly or meet your regulatory obligations? And I think there ought to be some rules. I don't think that councils need to have enough money, but they shouldn't be allowed. It should be unlawful to commission at fee rates below what it's possible to be compliant with regulations.
Thank you. And finally, Jane.
Thank you. Yeah, I think an intelligence-based approach to regulation and a proportionate approach is very important, and that's the direction that the CQC are travelling in. That intelligence-based approach needs to really draw on the experiences of people using services and people working in services. We're really clear that we're in partnership with the regulator because we all want to deliver the best quality care. The people who are best placed to tell us about the quality of what we do are the people using those services and their families. So I think we've got to constantly work on that partnership. And in the earlier session, you talked about the regulatory framework and how that will apply to the commissioning environment. I think that's going to be very important that lands well, because that could be a very positive step forward if it lands in the right way and is appropriately focused.
All right, thank you very much.
Okay, thanks, Bob. And thank you to our three witnesses. That's been really helpful to the committee. I think we've learnt a lot about the challenges and the problems facing care providers at present, and in a whole range of different ways that you provide care. And that's the important thing. There isn't just a one model, everyone in a residential home. It's very different, and I think it's making sure we understand those different aspects and variety of the way care is provided that's really important when we come to look at solutions going forward. So thank you very much indeed for helping the committee with that understanding. And that brings us to the end of our evidence session for today. Order, order. Thank you.
The proceeding has ended. The proceeding has ended. The proceeding has ended.